Let's see. Well, thank you so much for having me here today. Ivor, what a wonderful introduction. I wish my mother could hear about that. You know, I have really big shoes to fill in after this wonderful talk that we had just earlier. And, you know, I was standing back and thinking out what the discussions that's happened, it really highlighted one fact. You know, what's the greatest secret in medicine? Evidence is uncertain. And we're making a lot of assumptions, which is policy that's based on weak data. And had a huge conversation with Dave Feldman yesterday, and I was so impressed with his scientific endeavor and vigor. And you know, that is how I think nutrition science needs to happen. Nutrition science is one of the most uncertain that exists because not only that the evidence is not clear, but the reason is it's very hard to do. And folks like Dave and other, I think so, are showing us the way, what is the future of nutrition science, and hopefully that can change the policies and a lot of things that can happen. So now, and that's what we need, is we need to acknowledge, embrace uncertainty, and then work towards this and finding the answers. There's no right answer. So now I'm trying to go from the policy and maybe coming back to our closer interactions within the health system. And in this journey, I'll walk you through how the power of zero, in my humble opinion, is shaping a little bit of how, from a cardiovascular standpoint, we are viewing disease. It's helping us understand risk factors and many things more. So apart from some of the conflict of interest that I have, I'm on an advisory board of few pharmaceutical companies, and most of them is trying to ask them to lower their cost for their medications. So that's where most of my conflict is. But I'm also, some of the disclosures, and I'm also a big fan of low-carb diet. And my introduction has been last 10 years working with folks like Arthur Agustin and many others, and seeing the impact not only personally on my families and my members. I think that this really works. And it's not only about your lipids and your diabetes, mental fog, quality of life, everything else. Now, do we have great science? Not yet. And hence, this is, I think, so a group that needs to continue to advocate where we need to move into that. At the same time that I'm a big fan of low-carb diet, I'm also a big fan of statins at the same time. And, you know, that could be what we have seen in our society. We have seen more polarization. Either it's all about LDL, it's not about LDL, it's all about diet, it's all about medication. And I think so it doesn't have to be or. It's more about and. And more importantly, just because statin works doesn't mean all of us need it. It's cheap, it's effective, minimal side effects. You can use it as a vitamin, but the question is, do you really need it? That's the whole idea as a person, just because it works so well that you can put it in water and help overall at a population level. I'm a person, I don't want to take a pill if I don't need to. So I think so our conversation needs to shift a little bit. It's not about what works and what doesn't work, but who truly needs it, and it becomes extremely important among individuals, especially who have not yet presented with an established heart disease. And from that I mean prior heart attacks, any stents, bypasses, strokes. Because yes, while it makes more sense that individuals who have the worst disease and have established, of course, lifestyle still remains prime, but we have many tools which have again and again and again been shown to help improve. And just because they help improve doesn't mean everybody needs it. It should be more of an informed decision. But it becomes a problem for the vast majority of us who had not yet had a clinical event. And the question is, what should we do? Of course, lifestyle for everyone, but the question is, can you do more? And the basic principle is, if you have higher risk, we need to be more intense. That's a common sense thing. We need to treat you, should we treat everyone the same? No. People who have more disease They should be more intensely treated. And many folks among us who thankfully, for reasons yet unknown, who may be considered high risk and haven't developed disease, we should be more flexible. It makes more sense. We don't have infinite resources in the society. Most of us don't want to take pills if we don't need it. And in the end, rather than have a gunshot approach, we can do much better as a society by finding out the people who truly need help. But how are we doing that right now? I think so that's kind of the biggest problem in medicine and in cardiology. So think about it. It was only about 62 years back when the first time we even knew about this term, risk factors. The famous Framingham Heart Study gave us 5 risk factors, including cholesterol, diabetes, smoking. Of course, obesity was not an issue, a major issue, societal issue then, and that should also get into, neither we had an idea on insulin resistance, but how have we done? 2 decades ago, when the first guidelines, the major guidelines came in and how as physicians we should be using to, when you come and see us in the clinic, and decide what's your risk and help you guide with the management, we're still using the same risk factors. 10 years later, which was 10 years before, almost the same thing happened. So over the last 62 years, if you ask me how we've done from an innovation standpoint, where the way we travel and the way we drive and the way we call and we operate everything in our life has changed so much, how have we done innovation as far as predicting cardiovascular disease? Not so much. In all honesty, what we have done is we have taken the same few things, put it in our box, shake it up a little differently depending upon which side of the bed we wake up, and saying, here it is. And I'm not advocating a change just for the sake of the change. You and I need to question, and many of us have questioned, how well are they working? Because if they're working well, why do we need to change? My first exposure, which opened my eyes, was way back in 2003, post-medical school, seeing patients and using the guidelines, and a great paper came out. And actually, it was a very simple paper, and asked a question. What if individuals without diabetes, younger individuals who are presenting with MI, they would have gone into your clinic, and you have done this risk factor, how would they have predicted that? So if you look at this famous paper way back, it clearly underestimates the risk of young, high-risk individuals, where almost 90% of them would be considered low to intermediate risk. The green one is that. Think about the implication. You're telling them, you're fine, go home, nothing to do. Next week, they have a heart attack. And by the way, in my own clinic, I was seeing a lot of those. And we started fixating at that moment, why don't we change the paradigm? And of course, the issue was a lot of these individuals, apart from lifestyle support, could have been on aspirins and statins, which work at least in the high-risk group. They were denied. So now, 10 years later, to counter the original sin of missing a lot and say, okay, if the guidelines came and say, let's do one thing. Let's just open the gates, and let's broaden it for everyone. And with one stroke, almost 60% of the adult population became candidate for statins. 1 billion individuals worldwide. Think about that. If you're age 60, you are a candidate for statin, lifelong commitment. And many of you, if you're coming from New York, you may be realizing that the Staten Island's getting crowded. And that's the challenge. But there was also a new phenomena happening that the guidelines were not recognizing on the front end as physicians when you're speaking with the patients. And I'm one of them. And I'm saying, I'm healthy. I don't want to take a pill. Actually, when you do a survey, about 1/3 or more individuals, 2/3 or more individuals saying, I don't want to commit to a lifelong therapy, how effective, safe, and cheap, if I'm not at risk. And 25% people are willing to pay $1,000 out of pocket, $1,000 out of pocket for information if you can tell me I'm low risk. So this is happening in 2013. Now we're asking almost half of this room to be on a statin based on a risk prediction model that's now over-predicting. So that means if you come in my clinic and I'm saying, Joe, your 10-year risk is about 10%. That means 10% individuals like you may have a heart attack. It's a class 1 recommendation. You should take statins. When you actually follow them up, their risk is half. So this is just a highlight of how wrong the risk factors are. And so the question really started is, why don't we start focusing the money and looking at the certain law? Now, you can believe in any risk factor, God, whichever you want, be it glucose, lipids, stress, tobacco, pollution. In the end, they all funnel down and they don't cause heart attacks or stroke directly. They cause the actual disease is atherosclerosis, plaque buildup in your arteries. And in 2023, we're still figuring it out. There are many individual level who are susceptible. That means they are more prone to develop plaque, and a lot of them are resilient. And we are learning it's a lot of social determinants of health that's coming out into. So in the end, the question is, why don't we just focus on where the risk is? And of course, our favorite Arthur actually had shown us the way almost 32 years back with the simple CT scan without the use of a contrast. Takes 2 to 3 minutes, widely available. It costs about $50 to $150 nationwide on an average. And even when my daughter was 4 years old, I was able to teach her to pick calcification as a precursor on this disease. It's as simple as that. You don't need 20 years of training for that. And for the first time, we had an ability to look inside and say what's happening beneath the bonnet. And it took almost 20 years of resistance to even acknowledge the fact that that works, and that too with a wide range of studies happening in US and in Europe, and then eventually a lot of the studies, and I'm just gonna summarize it. It just says, among all the things that you wanna take into account, this is the most important, strongest predictor of your risk of having a heart attack. For example, diabetes, which is pretty bad, the risk is 2.5-fold. To compare that, if you had a very high calcium score, more than 100, which is considered moderate to severe, which is seen in 15 to 20% of individuals, the risk can go up to 10 to 16-fold. And this is the only one thing that can add up anything above. But not only this, way back in 2009, we said, what about if you looked at upside down? We're always looking for calcification. Well, what about if you don't have calcification, which we termed as, and then again, I was just a resident at that moment, and we jokingly said, well, this is the power of 0. And that really picked it up. And what we showed, unanticipatedly, we have no idea who those are. Almost half of the general population have no plaque buildup, and they are such at low risk that way back in 2009, when everybody was trying to put people on statin, we said, do you really need it? And do you really need any testing like stress testing or anything else? It's such a reassuring thing. Why not just focus on lifestyle on these individuals so that you and I'm a physician, I want to focus on the people who really truly need the attention. Now, there was a lot of resistance, criticism. It took us a few years to get even the papers published. Now they are one of the highest cited papers in cardiovascular imaging literature. But criticism starts coming in and saying, but what about people who have risk factors, who have severe lipids? They're not going to have a calcium score of 0. And even they have, who cares? Because in the end, we know people with high LDL or diabetes or multiple risk factors or inflammation, they're going to have an event. So are you telling us we should not treat them? And say, I have no idea. That was my response. Honestly, we just didn't have the data. But that's why I'm saying discord and disagreements are great, because it points us in a direction. If our goal is truly to help our stakeholders, our patients and society, we need to take that criticism and work on it. And that's what we did. So what would you trust more, your cholesterol numbers or your calcium scores? That was kind of the whole idea I had, and say, among individuals who walk in your clinic who may have the worst triglycerides, low HDL, which is insulin resistance basically, and have very high LDL, how many of them at age 60 would have a calcium score of 0? Any guess? 10%. So this is kind of what I'm thinking too. And what about people who have all their lipid parameters pristine? How many of them would have not only plaque, but very high plaque? Any guess? 25. So this is how, this was the state of 2013 and 14. As physicians, we're just making all the guess, and that's why I said the evidence is uncertain. Actually, as you see here, on the right hand, it shows 50% of individuals who have the worst lipid profiles. When I'm saying, oh my God, I'm so scared, actually have no plaque buildup. And on the other extreme, about 42% of individuals with the most pristine lipids have some plaque, with 20% with the high risk. Now, who cares? Now, when you take lipid disorders and calcium, as you can see on the left side, with a calcium score of 0, if you have the worst LDL, over the next 10 years, your risk of event is much lower than somebody who has a normal LDL and much lower, but minimal amount of plaque. Just minimal, I'm not talking about high. And once you get a calcium greater than 100, it just doesn't matter what your LDL is. About 25%, 1 in 4 individuals will have a heart attack or stroke in the next 10 years, which is considered almost a heart disease equivalent. Now, it doesn't matter how you slice and dice your cholesterol pie. You can look at HDL, non-HDL, lipoprotein A, you name it, and you're going to find the same result. The good thing about the calcium, it just doesn't discriminate. But what about, and then the momentum started and saying, okay, what about risk factors? Inflammation, which is a big deal. And we showed inflammation, risk factors, family history, aging. It doesn't matter. Almost 1/3 to 1/2 of those individuals would have a calcium score of 0. And for reason unknown, because you don't develop plaque, you are protected. So after the last guidelines, you say, well, what about the guidelines? Can we help shape the momentum there? And can it overcome the challenges with the biomarkers? So that's why biomarkers are all fallacy. Honestly, it's just going to give you a blind spot. And what we showed that by the last guidelines, 2/3 of the adults, if they just go to a physician, they would be considered statin candidates. If all of them had a calcium score, half of them would have no plaque, and their 10-year risk is going to be much lower than the threshold that even the guidelines is consider, not prescribe. And hence, we said it's not about screening, it's a decision aid. We want to empower the patients so they can make their own decisions whether they need to be on it, and I can give you the information whether you can be off statins or not. And not only that, we also showed, and I'm just going to summarize this, that calcium testing is really peerless because you can use any other test in your clinics, blood markers, family history, even a good healthy lifestyle, carotid, none of them can de-risk. That means get your risk level to a point where you can be safely avoiding therapies that you don't need. It's cost effective because you're introducing a test up front from a societal level, maybe in UK and Dublin, you need to take those things into account. It's shown to be cost effective. And we have also, and our groups and others have shown that you can take statin with a calcium score of 0 for 12 years or more, and it's not going to make a single difference in events. However, if you have a calcium positive, that's where the effect of statin starts coming in, and especially if your calcium is more than 100. If your calcium score is more than 100, that is where you only need to treat about 10 to 11 patients to prevent one event. So naturally, higher the risk, more aggressive the intensive treatment, the more benefit. But with the calcium score of 0, it doesn't make any difference. And actually, in 2018, after the guidelines, for the first time in 10 years, literally taking an idea from 2019 to 2010, in 10 years, we got it into the guidelines where national leaders are saying, you should be using this. It is, I would say, a tiebreaker. The president of the Cardiac CT Society is telling us, Ron Blankstein, that it can help reduce your risk, cut your risk in half. The American Heart Association, so people are getting on board. So I know there's a lot of skepticism about the guidelines and the medical literature, but I can tell you that if you do it right, you can get people on board. And this is the way to do it. And this is the way the nutrition science needs to happen too. If we want to get guidelines and everyone on board, let's create the evidence. Whereas the AHA is saying, president of AHA is saying that you don't need to prescribe statin for that. Scott Grundy, who's been leading all these cholesterol guidelines for the last 40 years, finally stood up and said, if you're not going to use calcium testing, you're going to put a lot of people on statins. Val Fuster, who's the chief of Mount Sinai, one of the most prominent cardiologists in the country, he's saying, if your calcium score of 0, forget statins. And Harlan Kromholz, who is the founding father of outcome research, is saying, this is the test that will tell you you don't need statins. So this is the evidence, and this is the path that we all need to pursue. But in 2020, I thought about that, okay, fine, I'm going to give up the calcium thing. It's already done, and we got the Arthur Egerton Award, so let's move on. But really, that's where the honeymoon ended for me. Personally, I can tell you why. And it reminds me, Star Wars fans here? It really reminds me of this scene when the rebels they're heading out from the troops, and they get into a compactor, and suddenly the wall starts moving in, and for the next 5 minutes, it's huge desperation. They're trying everything, and you can't stop, and then the R2-D2 goes into the back end and is able to find the solution. So, and how is this relevant to this 1977 classic, what we have? I can tell you because suddenly, well, in the early 2013, we didn't have Twitter or social media. So all our debates were happening in person, but suddenly what happened is a small contrarian, very lipid-centric, and very risk factor-centric group starts saying, well, some people are having events with the calcium score of 0. It doesn't last forever. It's not like diamonds. And you're asking people that you can share decision-making, that you can go off statin is like asking people you shouldn't be wearing seat belts. And the best part from David Brown is nothing like a good slogan to advertise a worthless product. I love Coke Zero, by the way. So now there is this group who's saying it's all about risk factors. Who cares? You have to start people early, much earlier on statins, even in their 25s. And I'm saying, wow, this is amazing. And then on the other end, which is the total opposite end of risk factors, they're saying, well, calcium doesn't work. It's all about the soft plaque. Now we have this big gun, the CT angiogram, where you inject the dye, and I can look at the plaque. It's all, heart plaque is stable, and 0 calcium doesn't mean 0 event. When would anything mean a 0 event? And the fallacy of power of 0, is it dead on arrival? So all of this happening at the same time, and as I said, it's never and, it's somewhere in between. So we have to roll our sleeves back again and go back and say, okay, fine, LDL greater than 190, something that Dave Feldman is working on. Severe hyperlipidemia, the guidelines give them a very special class. This is something not to be touched. This is a very high-risk group. You don't need to do anything. If you have an LDL 190, I don't care. You are a high risk. You need to be intensely treated. And for me, it's like, why not? Let's ask all the questions. And as you can clearly see, even with LDL more than 190, the blue scale means a calcium score of 0. About 1/3 have a calcium score of 0. These are men and women 60 years of age. And over the next 13 years, their 10-year risk of having any event is 2 to 3%. But at the same time, you also have to realize that a lot of these individuals will have plaque, and higher the plaque, about 25% will have a heart attack. And we felt that the power of 0 passed another test, allowing us to have a conversation with you all. Rather than dictating, our role should be more guiding and saying, I don't know what your risk is. Let's get a calcium score. If it's 0, then based on what your values and preferences, we'll work around it because your risk is low. We should have more flexibility. And then I can have a conversation if your LDL is more than 190 and a high calcium score that we need to be more aggressive. But then we went a step further. What about this whole LDL hypothesis? I don't think it is really a major initiator, but of course, causing progression. Individuals who are born with a genetic defect, that your LDL is 200 and 300 from birth. And if it's all about LDL, by age 40, 45, 50, your artery should be full of plaque. And what we found, by middle age, about 45% of those individuals have no calcification in their corneas. So there's something that doesn't fit into this lipid hypothesis. I'm not against it. I believe people with plaque and disease, we need to lower the fuel and the triggers. But there's some discordance about initiation of the plaque buildup. And then we looked in a study following them for 10 years, a median of 5 years. So with calcium score of 0, genetically confirmed FH, 45 to 50 years of individuals, they have no events. However, at the same time, I caution that if you are genetically confirmed FH and have plaque buildup, you are a much rapid progressor and more likely to have an event. So be careful there. That's where we need to bring in the big guns. And of course, it's not only about that. Now we know calcium testing can help you to understand if you need aspirin, if you need cardiometabolic therapies like Vascepa and icosapent ethyl, and even other things. And because I totally believe and agree with my colleagues, Dr. Medema, that in 2023, if we are going to make a decision about your risk and what to treat, is not only suboptimal, but financially unwise considering the cost that's happening. Now, looking into the future, of course, I'm a big fan of CT angiogram. For the first time, we can have a look into not only the calcification, but how the progression change is happening from the soft to the fibrous to the calcification. And however, if you look at the cupboard is empty, again, we're having conversations on things we don't have data. And that's why I went in 2015 started the only study in the country that recruited individuals like you from the community, 2,500 individuals, and say, I need to know what is the plaque distribution and how does it interplay with the calcium score, and does it add? Should we do a CTA? Who are the ones? And we published the first paper that was last year that showed significant, almost half of the individuals have some plaque, about 5% may have some blockages, about 8% may have some plaque features, what we called vulnerable plaque that we know not only for the long term, but maybe for the short term. So we're learning a lot. And even with a calcium score of 0, about 15% may have some early one streak of plaque. Now, I don't know what it means. Does it going to add on the risk stratification? Now, learning from the prior data, is the non-calcified, does it add a mile or an inch? I don't know. But at least I can tell you from 2 major studies, one for a short-term risk. For example, if your calcium score is 0 and you have some non-calcified plaque, what does it mean? At least in the short term, it doesn't mean anything. And a study that was done in England and Ireland took 3,000 patients who had a calcium score of 0, who had some plaque, and they followed them for 13 years, and they had no event. So it's kind of pretty reassuring. So just to wrap up, since 2009, calcium score has come a long way. It has been called a many thing, a mere slogan, a Pandora box, false, fallacy, a good slogan. But I think so it has stood the test of time. It has come to a point where a very lipid risk factor-centric society, medical society, is slowly coming to the term and saying, you know, actually, this is more important. Actually, we don't need to treat a lot of people. And I think this is the kind of the vigor that's needed even in societies like the low carb and the nutrition society. It's easier to sit up and stand and criticize every guidelines and every data. But we have to do something about it. And that's where I am so much appreciative of Dave Feldman and their group who are truly bringing in that scientific rigor. And I would love to work with all of you guys in getting that data out. So in next 10 years, we shouldn't be complaining about guidelines. We should be changing guidelines. That's what we need to do. And all of us, it takes a village for that to happen. And I'll just leave for, and then again, this is humor, but more importantly for people who believe statin is about everything. I just leave it at, if you have very high LDL and you have a calcium score of 0, you have a rare condition called good health. Frankly, I'm not really sure how to treat it. And if a doctor comes and tells you with that you need a statin, I at least want to disclose there's really nothing wrong with you, but this treatment will make me feel better. So again, thank you so much, and really appreciate Jeff for having me out here. It's been a fantastic effort.